Good day. Welcome to the 31st Annual BC Lupus Society Symposium. It's a privilege to be again with you sharing the space, and I am going to present a little bit of the research that we have been doing in the last few months regarding to a very important drug that is well known for you. I am going to share my screen with you, and I hope you can see my presentation. Thank you for the kind invitation. As you know, I am the BC Lupus Society research scholar, and it's a great pleasure to be with you again. What I'm going to present is the data on one of the most well-known medications in the management of lupus and in rheumatology in general, anti-malarials, which are included with hydroxychloroquine and chloroquine. Hydroxychloroquine, which was made famous by the person that we don't want to name from the US. We know it doesn't work in COVID, but it does work in lupus and in other rheumatic diseases. As part of the membership of the University of British Columbia, I don't have anything to declare as conflict of interest for this presentation. A little bit of history of anti-malarials. As you know, the anti-malarials were initially developed for the management of malaria, but they were used centuries ago without knowing how it worked. It was just known that the cinchona bark, which is a tree, and I give some examples in this slide. I hope you can see the cursor. And it was just given for the management of fevers, which later on was known that it was malaria. Also, the Chinese used this medication from a different tree that was Qinghao, and that was in the early 1600s. Then later on, it was known that quinine was the active component of the cinchona tree. And then later on, Paine used the medication for the treatment of discoid lupus, rheumatoid arthritis, and lupus. But then in the 1920s, chloroquine was identified as a substitute of quinine in Germany. And it was actually the first drug that was massively produced and approved by the World Health Organization for the management of malaria. It was known that it was a little bit toxic, and then a synthetic component, very similar, was developed in 1955, known as hydroxychloroquine or Plaquenil. Even though the hydroxychloroquine has lost its patent, and now there are multiple generic medications or drugs, it still sells a huge amount of money, around $900 million up until 2019 data, and it's projected that by 2027, it will be selling around $2 billion. So this medication is stay for a while in the market. So as I said before, it was used to treat malaria in the World War II. And in that case, it was serendipitously known to also benefit people who had rheumatoid arthritis or lupus, who went to war and received the medication for the management for prevention of malaria. Later on, after clinical trials that established the effectiveness of hydroxychloroquine, it became a very standard medication for the management of lupus. And we know it improves muscle and joint pain, very effective in skin manifestations of lupus, also some benefits in inflammatory lining of the heart and the lung, and other lupus symptoms such as fatigue and fever. Later on, it was also known to develop additional benefits, not just to treat the disease, but also to prevent complications. And we're going to talk about some of them today. So in a very recent study from the SLEEK cohort, the SLEEK cohort is a cohort of people who contribute data on an annual basis from different hospitals around the world. It's one of the largest cohorts that has been followed for many years. They represent a selected sample of people. Nevertheless, it's a very large cohort. And overall, in a recent study published this year, it was known that the use of anti-malarials prevent flares, and those people who are continuously taking the medication have 50% less chances of developing flares. And those flares could include manifestations in organs that are considered serious manifestations of lupus, such as brain and kidney, as well as spinal cord. Also, is well known, and I will present some data that patients who continue taking antimalarials actually live longer than those who do not take the antimalarials, in addition to other medications that may need for the management of lupus. Therefore, antimalarials are considered as lupus life insurance medication. Just as a show of how much I miss Vancouver, this is Gastown, and at night, and even though Barcelona is beautiful, I still miss home. So the epidemic of non-adherence. We know that the medication works. However, there is an epidemic of non-adherence. Non-adherence is defined as not taking the medication as prescribed. In 2017, a student of mine was doing a master's, and then as part of his thesis, he wanted to review the literature and identify how much is known or published on the problem of non-adherence. He reviewed the literature in a very structured way. You can imagine there was initially 4,000 papers, and after excluding and selecting and reviewing, we ended up having 11 papers for full review. And those are presented here. In this box, I showed you just the sample size of each study. Most of the studies were from North America. There's one Canadian. And you can see none of them was higher than 250 patients. But I want you to see what we found, or at least what he found. Overall, in these circles that you can see, it shows the proportion of people who were considered non-adherent. Non-adherent is defined as those people or individuals who do not take the medication at least 90% of the time as prescribed. So overall, we can say that around 50 to 75% of people do not adhere to the treatment. Half of the time, they're not taking the medication. And this is a big problem because we know all the great benefits that this medication has. The reasons for not taking the medication were not explored in these systematic review. However, we know that patients have different reasons for not adhering to medication. One could be side effects that actually happen, fear of side effects, economical reasons, as this medication is not covered, multi or polypharmacy, people who decide to take too many medications, and other unknown reasons, depression, etc. So these were not explored. However, this shows that the problem is real. There are other studies that have actually measured the blood levels of this medication to assure that the patient is actually taking the medication. And surprisingly, almost 50% of the time, blood levels are below the target if the patient were taking the medication. So it's a big problem. And there are some consequences, and I'm going to present some of the data on what we found. So again, adherence is defined as taking the medication as prescribed at least 90% of the time. In this study, we also wanted to assess what was the risk of developing diabetes among people who do not adhere to the medication. It is well known that one of the additional benefits of hydroxychloroquine is the prevention of diabetes. And in fact, this medication has been proposed as therapy to improve the blood sugar levels, or the sugar blood levels in people with diabetes. And I think it can actually prevent the development of diabetes in the general population. Anyway, so in this study, we wanted to see what was the outcome for diabetes if people take the medication or not. So as you know, in British Columbia, we have, as almost in the rest of Canada, access to free healthcare. And every healthcare encounter gets captured as the government has to pay for the service to physicians, to pharmacies, to hospitals, etc. Every time a patient goes to see a physician, the physician has to submit a diagnostic code for the reason of seeing that patient. Same when the patient goes to hospital, the patient gets discharged and up to 25 diagnostic codes get presented in a discharge summary for all the reasons that the patient went to the hospital and other complications that may have happened during hospitalization. In addition, we also captured data on cause of death, cancer, and particularly very relevant in BC, we capture all the medications that the pharmacy dispenses, regardless if you have extended healthcare benefits or not. Therefore, using all these databases, we can capture the health trajectory of individuals since 1990. We can know from, which local health authority they belong, postal code with 3 digits. However, this data is anonymized. We don't know who is who, and we just see aggregated data that allow us to follow any patient with a diagnosis, in this case for lupus, and all its trajectory since 1990 up until 2015, which is when we use this database. Currently, we have data up until 2021. So this is a very rich administrative database that can be used for research purposes. And again, just to clarify, the definition of what we define as adherent or taken as prescribed is the proportion of days covered, meaning 90% of the time patient was taking the medication as prescribed. The PharmaNet data, which is the data that allow us to access all the drugs that are dispensed by pharmacists, tell us the number of pills that were dispensed and for how many days. If you're supposed to take a medication, 1 pill a day, and you get 90 days prescription, then we know that at 90 days, you have to have a refill. If you go back and get your refill, we assume that the medication was taken all the time. However, sometimes there are gaps. People refill early or refill late, or forget some medications, and instead of getting the refill at 90 days, which is the maximum amount of time that the pharmacist can dispense medications, but you got a day 100, then there is a gap of 10 days. If that gap existed more than 90 days, then it was considered as non-adherent. But we were very generous and allowed to have gaps between prescriptions up to 90 days. And then we consider as overlapping, or patients took less dose because the physician prescribed 1.5 tablets instead of 2. So we divided windows of 90 days and allow people not to have, or to have a gap between windows up to 90 days. That was our primary analysis. So what we found? Well, we found that among 1,500 people with new onset of lupus who started the new drug hydroxychloroquine after the diagnosis, we found that when we allow at least 90-day gap, the people who have taken the medication at least 90% of the time, we found that they have a 39% reduction of developing diabetes. And then we create a sensitivity analysis, a more generous approach when we allow a 120-day gap, meaning you took the prescription 90 days, and then we allow to have 120 days with no prescription, and then you get a new prescription, and we consider these as if you were taking the medication. And then we did another sensitivity analysis where we allow up to 6 months of not taking the medication continuously. Regardless of how we do these permissible gaps, the risk was striking. People who take the medication 90% of the time get around 50% less chances of developing diabetes. And this is the key message for this. Therefore, if you stop your medication or you don't take as prescribed, the chances of developing diabetes are higher, or you have around 50% or 40% less chance of developing diabetes. So now, this is the key message. If patients who follow the prescribed antimalarial had around 40% lower risk of developing diabetes 2 compared to those who discontinue therapy. And then we move the analysis a little bit more. What if we allow only 80% of the time taking the medication as prescribed? When we move that, we lose the benefit. So you need to take the prescription at least 90% of the time as prescribed. So then we wanted to do a different analysis, and I want to see what was the impact of adhering to medication on the risk of mortality. Big outcome. And this is again a beautiful picture of the UBC campus. This is currently a PhD student, but he did as part of his master's project. Again, we use the same database from BC, where we capture everyone who has lupus, new diagnosis of lupus, who receive anti-malarials, and then we include them in the data analysis. This is again from 1990 to 2015, but we allow people to enter the cohort in 1997 because the drug data is available only since 1996. Overall, and we use the same rule, taking the drug 90% of the time and allowing gaps of 90 days as primary analysis between two prescriptions to be considered adherent. So patients adherent to antimalarials had 71% and 83% lower risk of death than patients who do not adhere, meaning they didn't take 90% of the time, could be 60, could be 70, could be 80, or definitely did not continue taking the medication. So big protective risk. And also we observe as the adherence level increased by one level, meaning if you decided to stop the medication, but then later on you decided to take it, but not as prescribed, this may take it 50% or 70% of the time, then your risk of dying decreased by 43%. If you are non-adherent and then go to completely adherent, then you decrease your risk by 43%. In other words, if you go from not taking your medication to adherent, you will get 86% additional benefit, right? Because you move from not taken to adherent. So 2 levels, you move 2 levels. I hope this is clear. So then we decided to go and explore further in a different study. We wanted to see what was the risk of cardiovascular mortality. As you know, cardiovascular mortality is one of the leading causes of death in people with lupus, followed by infections. And then we wanted to see, we know that hydroxychloroquine and antimalarials have a protective effect on the risk of heart attacks and strokes and blood clots. So we decided to see if being adherent has an impact on this cause of death. And this paper is actually under review and pretty soon it's coming out. So we're not supposed to present this data, so it's very fresh, but you never heard it from me. So the objectives of this study was to examine the association between being adherent to antimalarials and cardiovascular mortality in people with new diagnosis of RA, rheumatoid arthritis, and lupus. We decided to include rheumatoid arthritis as this is a bigger number of people suffering from rheumatoid arthritis than lupus, and cardiovascular disease is a rare outcome, so we wanted to have more power in our analysis. As I said before, we use the same data from BC, and our primary outcome was overall cardiovascular mortality. As I explained before, we have access to the DEATH file, the vital statistics files that list the primary cause of death and secondary causes that had contributed to the death. So if a patient died from myocardial infarction, we could identify that that individual died from a heart attack or infection or stroke. So we use a composite outcome, cardiovascular mortality in general, and then we individually look for the individual risk of myocardial infarction, which is heart attacks, stroke, and VTE mortality. Blood clots, if they are happening in the deep venous of the legs, it's called DVT. And if they happen in the lungs, it's called pulmonary embolism. And when they happen, either one or both are considered venous thromboembolism, also known as VTE. So this is the table 1 of classical studies. I don't want you to focus on that. I just want to put this on the numbers that we had. We include 70,000 people with rheumatoid arthritis, with new diagnosis of rheumatoid arthritis, who start using hydroxychloroquine as part of their management. And almost 3,500 individuals with lupus, new onset of lupus, and new onset of medication. In total, we have around 21,000 individuals that were followed since 1997 up until 2015. And this is one of the beauties of these data set, allows you to do quick snapshots or the trajectory of individuals along these years. So what we found was that people that adhere to antimalarials have a less risk of dying from cardiovascular disease compared to partial adherence by 52%. So those, if you take it as prescribed 90% of the time, compared to those who do not take it as prescribed, then you have 52% less risk of dying from cardiovascular disease. Individual risk for individual diseases, again, almost 50% for non-protective effect for dying from heart attacks, and 66% protective effect from dying from stroke. Surprisingly, we didn't see benefit from venous thromboembolism. But again, what we observe in these studies, the benefit get lost if you actually move the target from 90% to 80% or 70%. So it's very clear that adherence has to be at least 90% of the time taking the prescription as prescribed in order to get the benefit. And remember, the risk of diabetes, just to summarize what I just presented today, is 38%. So magic number between 40 and 50%. Okay, this is the benefits that you get from these if you take your prescriptions as prescribed. I want to thank the funders. These studies could not be done without the funding from the Canadian Institute for Health Research. And there is a lot of people working on this, students, scientists, biostatisticians, and other staff. So by having to present this, I want to encourage people, while we get the new medications of lupus that are happening, we need to state what we know it works, is cheap, and not only treats the disease, but prevents complications. One of the biggest fears of people that take hydroxychloroquine or anti-malarials is the risk of eye toxicity. In the old days, when we did not know that the daily dose was the big risk factor, the cases of retinal toxicity that could lead potentially to vision loss were higher than we currently have. Nowadays, we have new technology to make early detection before it becomes irreversible. And you probably heard the project that we're doing with one of our students who is actually an ophthalmologist and a retinologist, Dr. Narcis Daftarian. So you are going to be invited to be in this project, and we encourage you to attend and receive your care as usually. And I don't have anything else to say other than take your pills as prescribed. And if you do not, or you cannot do it, talk to your physician to find solutions to make you adherent. Thank you very much and stay safe. And I hope to see you in the questions. And I miss you all. Take care.